I'd like to move forward with Dr. Heathcock. Her title of her talk is Infancy and Neonatal Stroke, Childhood and
I'd like to thank the conference organizers for allowing me to present my current perspectives on cerebral palsy in research and clinical practice. And I'm going to do that in three main ways. So first I'm going to talk and spend the majority of the time talking about upper extremity control in infants with neonatal stroke. And I'll present some preliminary data on reaching performance in these babies, their early development of reaching. I'll also share some published data on their grasping abilities and motor skill development, and also look at some preliminary data on the treatment of these reaching and grasping impairments that we see. I'll spend a little bit of time describing early pneumatic behaviors in 3 teenagers before and after transcranial magnetic stimulation. And then I'll talk about a higher dosing clinical protocol that I think you will see some overlap with some of the work that Laura just presented in terms of dose, and how this project is a really clinician-driven project on how we can provide higher doses for younger children and children at higher GMF stance levels. So one of the reasons I'm interested in neonatal stroke is that it's often it is an injury to the brain that we can identify relatively early. We usually identify this with MRI, and that these children have risk factors for hemiparesis, which leads to disability or delay in upper extremity function. So one of the tools that I have been using recently in my lab with young infants, neonates with stroke and preterm birth is a non-sedation MRI protocol. And this protocol, I'm mimicking exactly what they do at WashU. For those of you who are familiar with their non-sedation protocol, we schedule babies on purpose 2 nights in a row. We scan them at nighttime, at their current bedtime, and we feed them right before they get ready for bed. There's a rocking chair in the MRI suite, so we put them to bed like they normally go to bed with their parents. And then we are able to, pretty successfully, we have a 95% success rate, scan the brains without any sedation. And if we include the second date that we're already scheduled for, so 2 nights in a row, if we include the second time point, we have a 100% success rate in getting non-sedation MRI. So here you can see an image of a baby who's had a stroke, and the injury is very small. And we know from lots of imaging literature that size and location are not always predictive of future function. So this child has a very small injury that turns out to have very severe motor disabilities. We can also get images, or we can also get information that look like this. This is volumetric analysis. So we can look at the volume of the cerebellum, and we know that in some infants who are born preterm and some infants with neonatal stroke, their cerebellums are actually smaller than infants who are typically developing, and this leads to questions about motor control. And we can look at the size of their ventricles. My favorite image is this image right here, which is a child, which is DTI. So we're looking at the pathway. This is a region of interest, so we're looking at the motor pathway from the motor cortex through the brainstem. And we can see it's the same baby, it's this baby right here, who has a very small lesion, but marked asymmetry in the pathway development. And I think that this might be an area where we can improve pathway development or perhaps use this as more prediction of future delay. In addition, if we take just a jump to reaching deficits in children with hemiparesis, so if you have neonatal stroke, you're at risk for hemiplegic cerebral palsy. So if we look at what we know about children in terms of upper extremity performance, children who have hemiparesis, we know that they have a lot of trouble with bilateral reaching skills. We know that they have poor hand function of their affected side. We know that they have lots of asymmetrical behaviors of their upper and lower legs. They show neglect of one side of their body, and they also show poor joint disassociation. So they might move their shoulder and their elbow in the same time, in the same direction, and be unable to voluntarily control one joint differently than the other. So for me, this is an area of opportunity. We know that early reaching skills are very important in early infancy, and we know that typically developing infants will reach out and touch a toy with their hands in between 3 and 6 months of age. and that this is one of the first independent skills they show. We know that they're spontaneous behaviors, so we call spontaneous arm movements flapping behaviors. So we know that babies spontaneously move their arms in early infancy, and we know that they perform something called a march to midline. So they start off using a workspace like this, and as they get older, their spontaneous movements march towards midline, and that midline is a precursor to independent reaching. With neonatal stroke, these children have an ischemic event or a hemorrhage during the perinatal period. This means that there's some sort of interruption in blood supply occurring between the 20th week of gestation through the 28th day of postnatal life. So this injury happens very early. Most frequently, this injury is focal, so it happens on one side of the brain in an isolated area. And the incidence ranges from what reference you look at to 1 in 1,600 to 1 in 5,000 births. The clinical presentations often the first sign that there might be something wrong with this child is a seizure. A nurse or even a parent might notice a twitching movement of the arms or some sort of seizure activity. And that child might be referred for imaging. It is not until much later that we might see a delay in milestones. And some of the outcomes of just neonatal stroke, there is 3% that might die from the neurological injury, 40% are considered neurologically normal, and then 57% have motor and or cognitive deficits. So neonatal stroke, to me, is an important contributor to the pathogenesis of cerebral palsy. And specifically, the incidence of cerebral palsy in infants with neonatal stroke is 30 to 58%. So hemiplegic cerebral palsy is the most common type of cerebral palsy from infants who have neonatal stroke. And the hallmarks of this type of cerebral palsy are asymmetrical motor performance. The upper limb is often more involved than the lower limb, and the distal part, meaning the hand, is usually more involved than the shoulder. So to me, this is an opportunity to look at reaching and grasping. So reaching is a very important early motor behavior that may be related to other motor and cognitive performances. And we know that if you have poorer reaching performance, we know that there is poorer reaching performance in another population that's at risk for CP, such as preterm infants. So one of my first goals was to study the reaching development in infants with and without neonatal stroke. So they come into the lab, and they're seated in this infant chair that if you have ever been in a baby lab of someone with a history from Zealand, they use this chair, and it allows free movement of the arms and the legs. We track their movements in 3D space, and we do a lot of behavioral coding. So in this experiment, we have 10 healthy control, full-term, typically developing infants, 8 infants with neonatal stroke, and we see them for 10 visits. So they start at 10 weeks of age, and they come into the lab every other week. And the first variable that we look at is very simply how many times do they touch the toy. So here you see the baby touching the toy. We're just counting the number of hand-toy contacts. So the first question was, are there any differences in the number of times babies who have a neonatal stroke, where 30 to 58% of them are going to go on to develop hemiplegic cerebral palsy in typically developing infants? And the answer to that question is no. There were no differences in the number of hand-toy contacts between groups. This seemed a little bit surprising to me. So the next question is, what happens when you look at asymmetry? So this first graph here shows you the number of times that the child reached the toy in 90 seconds. And this is over developmental time, so 10 weeks of age and 30 weeks of age. Visits every other week. And the blue line is the right arm, and the red line is the left arm. These are the full-term healthy controls, and you can see that there are no differences. They touch the toy equally with the right hand versus the left hand. If we take a look at the neonatal stroke group, we divide them by affected side versus unaffected side. The non-affected side is the red, and the affected side is the blue. And you can see that after the very first visit, where they're not touching the toy at all because they're too young to reach, that there are differences in asymmetry. So the non-affected side touches the toy more than the affected side. But there's also, if we look at trajectory, there's an increase in the amount of times they touch the toy over developmental time. So then if we look at grasp, so this is when the babies are laying on their back in supine. Toys were placed into each hand, and we look at the percentage of time they do bimanual manipulation of the toy, so grasping with two hands. And this variable was chosen on purpose because we know that children with heimparesis are bad at these kinds of skills and bad at play with bilateral, or bad at bilateral reaching. And what we see is that the typically developing infants in the blue spend much more time manipulating the toy with both hands than the group in red, which is the neonatal stroke group. Although also their bilateral performance improves over time. These infants are the same infants as those that were in the reaching study, but you will note that we stopped at the 6th visit because this is when all the babies started rolling over, and this was a test that we did in supine. In addition, we looked at the Bailey Scales of Infant Development version 3, or edition 3. We looked at their fine motor skills, and we compared the typically developing infants to the neonatal stroke infants, and you can see at every single time point, there is a difference between groups. This is true in fine motor, as you see in this graph, and true in gross motor here. None of the children in this group met the standard score on the Bailey to receive services for that reason. So this, I think, is an opportunity to use some of the things we know about early stroke performance in reaching to improve their reaching performance in a targeted way. So we use a couple different kinds of activities that have been well described in the full-term literature by Michelle Lobo and Paul Galloway, and I also used some of these similar training protocols in preterm infants, but now I'm applying it to infants with neonatal stroke. So in this picture right here, you have a parent and a baby. And the baby has Velcro mittens. This is taken from Amy Needham's work with sticky mittens. So a similar protocol is followed. You show the baby their hand, you show the baby the mitten that has Velcro on it, you passively move the infant's hand up to the toy in a midline position. The toy sticks to the mitten, and then the baby can explore it in their mouth or change hands. And then you also allow a period of active exploration. So you show the baby the game, but then you allow active exploration of the toy as well. Then we have an infant here who is tethered with a soft ribbon around their wrist and a toy up here. This is teaching the baby that any kind of movement is good, and that that toy, when you move, it causes a response from the toy. So here, anytime the infant pulled on the string, the parent would shake the toy and say, "Yay, baby," and teach the baby this cause and effect game. Then specific for neonatal stroke, we included a training program that includes bilateral skills. So here you have a very soft elastic cuff that goes across the baby's chest and loops around the arms. And all this is really doing is providing a little bit of gravity assistance so that they can spend more time with their hands in midline. So here, and the rationale for doing this is that we know that midline experience is important for reaching. We know that children with heimparesis have poor bilateral reaching skills, and from the preliminary work in my lab, we know that infants with neonatal stroke have poor midline behaviors and exploration of the toy. So in these examples, the parent does a similar protocol. They show the infant both of their hands, they show the infant the toy, they bring both hands to the toy, and then they allow the child to do that on their own. In addition, because we know that a certain portion of these children are going to go on to have hemiplegic cerebral palsy, we wanted to teach them how to do single joint movements. So the training program also includes putting 2 fingers worth of pressure on the bicep and holding the toy over the elbow and teaching the baby to move the elbow joint only when contacting and playing with the toy. And so our rationale for using this kind of movement is that infants with brain injury show more coupling, and that children with heimparesis have difficulty in disassociation. So this is very preliminary work on the training program. We do not have enough power at this time to detect statistical significance. So in the blue line, we have the control group, and in the red line, we have the treatment group. These are both groups of infants with neonatal stroke. One group received training and one group did not. And you can see that starting later in the protocol, we start to see what we think will continue to be differences in the number of times they reach per minute. In addition, if we look at graphs, we see what we think might be even larger changes in the percentage of time they spend doing bimanual toy exploration with this home training program. So my perspectives on current research and treatment of infants with neonatal stroke is that I think we can do a better job of earlier assessment of infants with neonatal stroke. In all of these measures, we have found differences between typically developing infants and infants with strokes, and that's in motor skills with the Bayley test of infant development, in midline behaviors, and in asymmetrical reaching with the upper extremity. And then in addition, I think we can do a better job of providing targeted treatment programs to target the actual impairments that these kids are demonstrating. The next project is a case series where we're looking at children with heimparesis, and we are analyzing the kinematics of their reaching movements. In this task, you're going to see a teenager with heimparesis reach to a target. The target is a touch screen, so when he touches this center red circle, it will go away. He's going to touch it once with his unaffected arm, once with his affected arm, and then once with both arms together. And you can see on his second reach, that's when you can see his affected arm. You can see he doesn't touch it with his finger, and he has poor hand control and some poor reaching ability. So this project is in collaboration with Nationwide Children's Hospital, which is the large children's hospital in Columbus. And I do the biomechanical testing before and after they receive transcranial magnetic stimulation. This type of stimulation is a protocol that is new, and it's using repeated transcranial magnetic stimulation contralateral to the lesion, so they're stimulating healthy tissue with the idea that this will inhibit and allow for more voluntary control. The protocol involves 8 days, and they do it 4 days per week for 2 weeks. And then what we're doing is looking at the kinematic profile of the reach. So here you have a child with a stroke in this protocol. So you can see that he has one primary movement unit. This is the velocity profile of the reach. So there's an acceleration phase where he accelerates, and then a deceleration phase, and then this cuts off when he hits the target, exactly when he hits the target. So for all of the 3 children we've had in this protocol so far, the range of peaks in their velocity profile is 3 to 7, and all of them have decreased after the treatment. We find that their acceleration phase in all of them is shorter than their deceleration phase, and I think this has part to do with the task. We are asking them to be very accurate in touching, even though that target was big, there's a bullseye in the middle, we have asked them to be very accurate in touching the target. And their peak velocity, all of their peak velocities were very similar and remained the same. So here are the 3 subjects that we've had. So subject 1, subject 2, and subject 3. This is pre-TMS, post-TMS, and this is just an example of the unaffected side. So you can see that there's, in all 3 subjects, there's a decreased number of movement units following the TMS treatment, which hopefully means there's an improvement in coordination. Some of the other variables we looked at were hand strength. For each of these 3 participants, hand strength improved. There was no change on the PD and no change on the shoe. So what I think is interesting about this in terms of application to research and treatment in cerebral palsy is that in these 3 subjects, there are interesting improvements in coordination. I don't know of anyone who has described improvements using kinematics following TMS in children. I would like to add joint kinematics. We just haven't done that yet. You can see that there are markers on all of their arm. And I think this might be an opportunity on how to leverage function. There was no training in this protocol, no task-specific training, no PT. So I think this could be an opportunity for providing a burst of treatment during a TMS time, and possibly in combination with CIMT or habit. And there is a recent publication. Bernadette has published a paper looking at TMS and CIMT. And some of my subjective thoughts of this is that these were not really children but teenagers, and this was a tough group to work with. They were not, all three of these kids were not all that motivated to be there, even though their parents were motivated to be there. So I think this is an area that, it was something that I was not expecting. I'm used to working with happy babies and sort of crabby teenagers who are new. So if any of you are working with them, you can please help me out. But maybe using a social program or a camp model might work well with early teenagers as well. So the final study I'd like to talk with you about is using a higher dosing clinical protocol. And this project is also in collaboration with Nationwide Children's Hospital. This was a 100% therapist-driven protocol, and they came up with this great name for it, STRIVE, which is skill therapy focused on repetition, intensity, variable practice, and education. So you can see that they're really drawing from the motor learning literature. So one of the concerns within the clinical therapies department at Children's Hospital was that there were several higher intensity and higher dosing protocols for older children or children at lower GMFCS levels, so higher functioning children, as Laura discussed earlier. So at Children's Hospital, there's a treadmill training program and there's a CIMT program for older children with heimparesis. But there was a lack of intense programs for younger children and those who are non-ambulatory. So their clinical protocol was based on motor learning. They wanted to provide lots of repetition, and they wanted to provide variable practice and allow for error, as Laura talked about earlier. They also wanted to provide treatment that was individualized to the participant, and they used outcome measures, the GMFM66 and the Bailey scales of infant development free. Each participant in this protocol focused on 1 to 2 specific goals. They didn't use goal attainment scaling, but they did focus on 2 specific goals. And examples of those might be propped sitting or commando crawling or walking with an assistive device. The dose was 2 hours per day, 5 days per week for 4 weeks. And I want to point out that this equals 40 hours of treatment. All of the participants did 85% of that dose or more. There were 15 patients with so they were targeting younger ages, and so the mean age of these children was 26 months, and all had a diagnosis of cerebral palsy. They were also targeting lower functioning children, but received children from all 5 GMFCS levels, with slightly more in the higher GMFCS levels. So the results on the GMFM66 from pre to post increased and was statistically significant. And if you look, this is a plot of all of the individual children, and it's my favorite graph because you can see that every single child improved over this 4-week period on the GMFM66. If one of the questions we wanted to know was when's the best time to intervene, so we looked at the change score on the GMFM66, so each individual child's change from pre to post, and mapped that to their age. And you can see that there's a medium negative statistically significant correlation. And what that means is that the younger children had greater improvements or greater change score on the GMFM66. So it seems that younger is better for this kind of intervention. In addition, a subset of the children, 8 of these children, had complete Baileys done pre and post. And there was also an interesting, there was a large correlation, but it's only a trend. So there was a large effect, an R value of 0.6, of children with greater change on the GMFM66 compared to the Bailey cognitive score. So what that means is that children who had a greater change score on the GMFM66 showed higher Bailey cognitive scores. So from this project, my current perspectives on the research and treatment of young children with cerebral palsy and higher GMF levels is that a higher dosing of greater than 30 hours a week was feasible in an outpatient urban children's hospital. In addition, I feel like this number of greater than 30 hours keeps coming up in the literature. It keeps coming up in the literature in CIMT, and I think it's going to come up in the literature in treadmill training, that this seems to be a minimum amount of hours where we see a significant change. In addition, younger children did better than older children, although they both improved. And that lower functioning children also might have done, lower functioning children tolerated the program. And their parents tolerated the program of bringing them to the clinic every day. So this protocol appears to improve gross motor function. younger ages are associated with greater change. And importantly, it may impact multiple domains of development because no cognitive tasks were specified in the protocol. And I think in the future, use of goal attainment scaling might be helpful in analyzing this kind of project. So almost all of this work has been funded by the Foundation for Physical Therapy in various ways. And I'd like to thank my collaborators at Children's Hospital as well as all of my lab mates. Thank you.
Entertain a few questions. Do you have some? Okay, I'd like to ask one. We did do some preliminary work in cortical anatomy. So that is a different application than that's what we usually think about when we describe the actual therapeutic application.
So I kind of a little bit. This is a collaboration with a neurologist, and he's the expert in TMS. So I can explain to you how I understand it. So there are different frequencies that you can stimulate the brain to induce changes in the ionic current. And there are ways you can stimulate the brain that are excitatory and ways that you can stimulate the brain that are inhibitory. And in the adult literature, both have been studied and studied in adults with strokes. So you can stimulate the affected side of the brain, so the lesion side of the brain, and try to excite that, or you can stimulate the healthy side of the brain and try to inhibit that with the idea that there might be some maladaptive overgrowth of the good side of the brain, so you're trying to inhibit that and allow for more voluntary control. So I do not think, and you can correct me if I'm wrong, I don't think anyone has stimulated injured tissue in pediatrics. So right now we are stimulating the healthy side and there have been several centers that are looking at safety and efficacy.
Given the stimulation on the unaffected side, do you know how that affects bimanual performance in these kids?
So I have not analyzed the bimanual performance yet, but if you saw that child who reached to the target, he does what we expect. One hand follows the other, his affected side follows the other, but there's some mirroring of movement. And so I will have those results in this sort of case series.